Thank you, Jay. I'll just move on because I think there is a lot of similarities with the previous talks, which was on GA, although there was a mention of many markers of intermediate AMD. So these are my disclosures. So first of all, the previous speakers, when they talk about GA progression and reducing the progression rates of GA, we are trying to see how we will reduce the cell death from already existing areas of cell death, as you can see in the GA picture. What I'm trying to focus is in the stage of intermediate AMD, when such cell death at least are not visible in ordinary imaging techniques. So we have previously always classified AMD based on color photographs, and the Beckman initiative is the most commonly used one. So today the focus at present is on intermediate AMD, where you have large drusen and or pigmentary changes, and that can be associated with a large number of medium drusen as well. So far we have been focusing on the advanced form of GA and neovascularization. So for intermediate AMD, as many of the previous speakers said, drusen, large drusen is the main disease characteristic and associated with RPE changes if they are available. Now, pigmentary changes are very similar to hyperreflective foci you see on OCT. So there may be hypo or hyperpigmentation. If you don't have those devices, color photographs are still very good predictor of progression. So previously at the time of ARIDs and other preventive measures for intermediate AMD, the endpoints were drusen area enlargement or drusen size, and I won't go into that, but that was how we measured it on color photographs. And you know that we needed about 6,000 patients to have an endpoint on whether preventive treatments are necessary or not. So here we are in the same situation with, if you have another drug, like we have elameprotide, we have photobiomodulation, we have several other drugs in the market that are being trialed on intermediate AMD. But the one thing we should try and make ourselves cost efficient in running clinical trials is that we can't get every intermediate AMD into a trial to look at progression, because there's very low likelihood of progression from intermediate AMD to GA. Per year incidence is only 3%. So in the ARID study, the rate of progression from intermediate AMD to late AMD, either GA or wet AMD, was 27% over 5 years. So it's very, very slow progression. So if we had to do a clinical trial on prevention at the state of intermediate AMD, we would need 1,000 patients to get just 30 eyes that progress to GA. So it is not at all cost efficient, and that is why newer trials need enrichment of the intermediate AMDs with high risk of progression. So of course we will all end up with using AI to identify these group of patients, but before we go to AI, we do need to understand the anatomy and pathology of why these markers are identified by AI. So coming to inclusion criteria, we discussed drusen volume today using OCT, and someone mentioned about drusen volume of more than or equal to 0.03 millimeter cube. They are 4 times more likely to develop late AMD, and I should stress, once you have a GA, there's no point going and looking at drusen volume, because fundamentally it is the GA growth rate that's more important in those eyes. I think, Jay, you asked about what device you would use. At present, we could use the baseline RPE drusen complex or the thickness, because that's been shown over and over again that it by itself can increase, is a high odds of developing central GA, as high as 32% for every tiny 0.001 millimeter cube increase in baseline thickness. Drusen reflectivity was also mentioned. Again, I should stress this is only important in eyes without existing GA. So high-risk drusen, we saw the color photographs. In addition to that, if you're using OCT, is a change of homogeneous to heterogeneous internal reflectivity, a drusen core, hyporeflective drusen, and hyperreflective foci. There are loads of papers on this, but I think this one gives you a sort of a summary. So the first A and B slide show hyporeflective drusen, which are at risk. And then the next two, C and D, shows medium-sized reflectivity. So you have to just look at the outer E is at ELM above the drusen to see whether there is any change in that in terms of reflectivity or loss. And then you see E, which is the core, and then next one is SDD. And G and H are all signs of hyporeflectivity as well as drusen core. At present, hypotransmission defect is also a very good sign for drusen. When you have OCTs, if you have hyporeflective drusen, they are most likely due to calcific drusen, which is high risk of atrophy. Hyporeflective foci and vitelliform were both mentioned already. They are all, if you see hyporeflective, then go back and look at the outer retinas. It will give you suggestions of high-risk patients. Hyperreflective foci is already mentioned, so I won't go into that. Nascent GA is another recent discovery by Robin Geimer's group, which shows subsidence of outer plexiform inner nuclear layer and the hyporeflective wedge-shaped lesions. This is a typical example of nascent GA. They don't need a hypertransmission defect, but if you have a hypertransmission defect in the choroid as well, then it becomes a iRORA, and it should be less than 250, because once it's above 250, then it becomes C-RORA. And the most important is hypertransmission defect. That is now extremely important because these are the ones that are included in trials as high rates of progression. So I'll just go through the hypertransmission defect. So if you see grade 0, there is no hypertransmission defect, and grade 1 is from hypertransmission from 40 to 249. And persistent, this is the one that is the most important. If you have a persistent hypertransmission defect of more than or equal to 250 micron, then that is a definite sign of impending C-RORA. And then, of course, you can count them or look at the rate of progression on them. I know Jay mentioned about using NFAS, but you could use spectralis, but you do need 97 line scans or higher.
Shobha, can I request you to wrap up?
Yes. For eligibility criteria for new intermediate AMD, you should look for central location of drusen only, and the drusen volume of at least 0.22 millimeter cube plus hyperreflective foci or plus hyperpigmentation with no persistent hypertransmission defect and presence of nascent GA. If you include them, then we are likely to have a smaller sample size. And for endpoints, of course, you can still go for GA and wet AMD, but we could still look at progression of hypertransmission defects. Thank you.
All right, thank you so much. That was very nice talk. And so I just wanted to ask you, Shobha, that do you really wish to subclassify intermediate AMD in coming days, where we can talk about really an early intermediate to an advanced intermediate, because we see the things changing while they are intermediate?
That's exactly right. So if I have an intermediate AMD, you have to classify whether it is plus SDD or without SDD, visible SDD on at least 2 multimodal imaging. And then you can look at whether it's associated with iRORA and, or a combination of these, because these are the ones that are likely to progress. Of course, hyperreflective foci is always important. Yeah.
And I think one of the very common questions asked, especially by fellows, that okay, now you are worried about the drusen reflectivity. What do I worry about if I see just 1 or 2 drusen ooze areas, or do I see 1 or 2 calcified drusen areas? So what is the threshold of putting them into higher risk on the basis of just reflectivity?
If you look at reflectivity alone, even 1 crystalline drusen or calcific drusen is enough to cause atrophy in that area. So I think these are very important signs. If you take 100 intermediate AMDs, you may see 1 such patient. So it's not like every patient will have that, but we have to look out for that. And that group of patients are the ones probably, I'll say, go on a Mediterranean diet or improve their nutrition much more. I mean, you can advise that to everyone, but these patients are the ones who really are going to progress.
And I just wanted to bring up what you nicely said in one of the early discussion points, that you guys don't prescribe AREDs, and we just submitted a very interesting paper where we picked up all our 10 years, we picked up all our patients who were on AREDs for 10 years in real life, and they are like diligently taking AREDs, and we did not see any special benefit of using AREDs in real life. So
because the tendency for healthy diet is up and running everywhere around the world, right? We all want healthy food nowadays. So I think it's a big confounder,
Yeah.
healthy food. Yeah.
Yeah, and I think AREDS is not an alternative to healthy diet. Any other questions for Shobha?
You know, the phenotypically, when you see geographic atrophy, actually, if you really look at it, you have three different types of, at least three different types of changes when you do the OCT. You can have the aurora picture. You can have actually what you say outer retinal atrophies, so outer nuclear atrophy. So you have not aurora, but actually the whole thing is coming down. And then you could have what I actually sometimes label as RPE atrophy, which you are calling as thick DLS. So the all three of them will give you the same kind of picture. Is it possible that they behave differently to treatment also? So if you take all three of them as one, your results may actually get affected, and you may get no positive response where a particular group works and the others don't. So I think it's very important that this categorization be not just phenotypic on the fundus photograph, but also based on OCT. And the second thing is the locational thing, which is not being paid attention to. Like, for example, if you have this crystalline drusen you're talking about, now if it's extrafoveal, it doesn't really matter, isn't it? Supposing there's one such, if it's foveal, it's a huge problem. But if it's extrafoveal and it's only one such, and the rest are only a few small drusen, the whole thing changes.
Oh, so I need to stress that a calcific drusen is a sign that the whole of the Bruch's membrane is calcified. So we have to be very careful, even if you see one calcific drusen.
So would you consider that for?
High risk case, yeah, it is a high risk case, yeah.
Adnan?
Just a comment on the AREDS. So I think there's lots of complexity about the AREDS trial, one of which is the subgroups were predefined in a methods paper, and patients with bilateral intermediate AMD had no statistically significant benefit because the event rate is so low in that group anyway. Where there is a really strong benefit is neovascular AMD in one eye, and is a 20-25% risk reduction in the fellow eye, and it's dominantly cost effective. So actually, on a governmental level, if you gave all patients with neovascular AMD in one eye and intermediate AMD in the other eye, AREDS, it actually saves the government money because it prevents a lot of very expensive anti-VEGF. So I don't actively recommend it for intermediate AMD, but I don't dissuade them from using it should they wish. The only group I actively recommend is neovascular in one eye, and it's the only group there was any statistical benefit.
And I completely agree, and that is something similar. We saw that even because one of the very commonly prescribed drug, as you may know, by every optometrist is give AREDS as soon as you see one drusen, which did not make any difference.
And you wouldn't expect it to from the trial.
Yeah, absolutely. Coming back to Dr. Talwar's point, and I think this is where we all are struggling or going to struggle further, that in spite of 2 drugs getting approved by FDA, we still are not able to really get a clean phenotype for any of these diseases. Because if we really talk about intermediate AMD, I don't think that we are still able to get a clean phenotype or make subgroups of multiple phenotypes. That's going to be one of the biggest challenges in coming years.
So I think if we get the drugs approved wherever, I think the important point is you don't need to rush into treatment, right? So if one eye has already had a foveal involving GA, then I think there is a necessity to start quite soon. But if it is a patient, first eye involvement, whether they have intermediate AMD in the other eye or in the same eye, I would rather wait to see whether that eye progresses before you jump into a lifelong therapy and expensive therapy.
Yeah, and I think that's something you should convince European Union. Marian?
A question to Sobha, but all of you. Regarding other drugs, I mean, there are so much registry trials nowadays, like on statins, on metformin, on, I don't know, melatonin. Are you kind of consulting your patients? Like when you see, for example, that a patient is taking statins anyway, for example, or when a patient has a threshold insulin resistance, something like that. Do you kind of bring these kind of drugs up, or do you think there's still not enough data there to kind of discuss it with the patient?
So are you asking whether we will continue metformin or statin?
No, just, I mean, there are so many drugs which are discussed nowadays, like, as I said, metformin, melatonin, statins. Do you bring this up when you discuss it with the patient, or do you think there's not enough data yet to just discuss it with the patient?
So at present, I do tell the patients there are lots of ongoing trials, but I do not suggest to do anything further. I said time will come and we will let you know. That's where we are.
I'll just close with one comment, Marian. Last week, there was a large big data paper disobeying the metformin is useful. So I think still the jury is out. So we will move on to the next talk. Thank you so much, Shobha. And the next talk is by